My panelists, the first one, Dr. Jayant Kumar Prakash. He is a consultant ENT and fusion plastic surgeon. He is the founder president of ISPARO, which stands for Indian Society for Facial Trauma, Aesthetics and Reconstructive Surgery, specifically designed initially for otorhinolaryngologists, but we have a lot of oromaxillary surgeons, dermatologists, plastic surgeons, reconstructive surgeons among us. And he is the current director of Kalingaraya Medical Center here. And
could I invite you up to the campus as well?
We are delighted to have Professor Dr. Gangadhar Sundar. He is a head orbital and oculofacial surgery, National University Hospital, Singapore. And my dear friend and mentor, Dr. Arun Kumar Arunachalam. He is a consultant maxillofacial and he is an excellent oral oncosurgeon trained by Professor Ravi Kannan sir. And he is a consultant maxillofacial and oral oncosurgeon in Poonam Hospital also. And Professor Dr. Rajesh Yadav. He is HOD of Department of ENT Head and Neck Surgery, Baba Sahib Dr. B. Ambedkar Hospital. He is a government municipal hospital in Mumbai. He is upcoming president of ISPARO. And we have Dr. Siddhi Agarwal among us. She is a consultant ENT Head and Neck surgeon and she is doing a lot of facial maxillary surgery in Mumbai. Just to introduce the panelists, you would have noted that we have an maxillofacial surgeon, oculoplastic surgeons and ENT surgeons among us. I actually wanted to introduce a neurosurgeon into the panel. This says that facial trauma is a teamwork. It cannot be done as a single person. If you are gifted being in a multi-specialty hospital, that's different, but if you have a single center also, you form it your team. Now comes the basic question. We have read about facial trauma. It is a part of our ENT curriculum and most of us would have written long questions on default fractures. And during our COVID time, most of us would have done maxillectomies or even assisted maxillectomies. And we would have done mandibulectomy, mandibulotomy, neck dissections. And some of us, before the endoscopic era, would have done an external frontoethmoidectomy. And we do excellent nasal job. But when it comes to osteosynthesis, linking and screw, we refrain ourselves. Why is that? The idea is to reorient our excellent surgical anatomical knowledge on the head and neck area in terms of managing the trauma. As I passed out, I was actually literally searching for such platforms or workshops where ENT surgeon could learn about facial trauma. And the first question is to Dr. Jain sir. Do we have such workshops or conferences?
Yes, obviously we, with the help of my mentor and Professor Mohan sir, we formed a society called ISPARO, that is Indian Society for Facial Trauma, Aesthetic and Reconstructive Surgery of otorhinolaryngologists. Though initially we started only for the ENT, but it is for those who are interested in facial plastic. That's it. It includes the team, as Anbu said rightly, it's a teamwork. It's not a domain of one person or something like that. We need an oculoplastic surgeon, maxillofacial, ENT, as well as head and neck surgery. A lot of combination of things is required for this to get the best results. Anyone can do anything, but need a best results. And as Anbu said it's rightly that initially there was no training programs for any of the ENTs as such before. And so that we started a training program in 2013 with the help of Professor in IOHNS, and We have a facial trauma that is particularly workshops conducted. That is Face Academy. We conduct every year. We have one program which is conducted either in Madras or in Europe. And also the ISRO is a very good platform for learning those who are interested, not only for ENT, for any other subspecialties.
Truncate this session to half an hour so that you get your lunch on time. Because you know the belly is very important. So I was asked to talk a little bit about tones, and I don't know, just members of the audience, show your hands. How many of you are familiar with tones? Can you open the presentation? So we're going to keep it very simple, very brief within half an hour. And basically, tones is transorbital, like how you have transnasal is transorbital. It's a neuroendoscopic, so you use endoscopy, but using endoscopy to the neural or the skull base or intracranial space surgery, transorbital neuroendoscopic surgery. You may or may not have heard of the other acronym called NOTES, which is a natural orifice transluminal endoscopic surgery. So they do it for other body parts, including the GI system. We do it for the lateral system, where we now have, like a side endoscope, which is 1.3 millimeter. We now have 0.9 millimeter micro endoscopes, which can go down the lateral system, identify the level of obstruction in the lateral system, recanalize with balloon and intubation and so on and so forth. That's NOTES. This is tones. Some new exam question for the examiners to ask, whether they attend the South Zone meeting or not. So why is tones becoming popular? We are now familiar with accesses to the orbit. Craniomaxillofacial surgeons have always been doing it. You heard in the previous sessions, transconjunctival approaches, transcutaneous approaches, transnasal approaches. And so access to the orbit is becoming very familiar for most of us. But we are now using the orbital axis to access the intracranial space. So what was considered a complication in the past, oh my God, we entered the brain, is actually an opportunity for us to modify the technique to access certain parts of the intracranial space. And the parts we can access are the anterior cranial fossa, the middle cranial fossa, and the lateral cavernous sinus region. Most transnasal surgeons are very comfortable going to the sphenoid and even doing cavernous sinus surgery, right? So you are familiar with that, but this is another opportunity to try to work with the orbital oculoplastic surgery. The advantages is multifocal. It's a multi-angled approach, like how when you do transsphenoidal surgery, the rhinologist gives you access all the way, then holds the endoscope while the neurosurgeon does his or her part. It's a multi-angled approach to the anterior cervical base, and you can actually manipulate various parts itself. The nice thing about it, you can get to the skull base without a large, big craniotomy approach, either hemicoronal, pedional, or the full coronal approach itself. The surgical mobility is quite low, and it's very cosmetically acceptable because we have eyelid creases, we have conjunctival folds, all the scars are hidden into this area. So you can hide the scars without shaving off the hair and putting staples on the scalp, giving alopecia to these patients as well. And gives you a two-surgeon access and two-surgeon manipulation. I have assisted in surgeries through the transnasal approaches, massive craniofacial tumors, sinoorbital tumors, where we have 4 instruments in the nasal cavity. The surgeon has got 2 instruments, the assistant has got 2 instruments, and every new 4 instruments can go to a nasal space. And it's amazing. Sometimes you even take off the septum and go across to the other side. So I've learned a lot from our rhinology colleagues working over the years. So what are the approaches we have? We have the transparental approach, or preparental, or we call it the retroparental approach, which is just behind the parental. It gives you direct access to the medial wall, to the supromedial wall, which is where the skull base is. We used to use this eyelid approach, external approaches, we don't. We love the superior eyelid crease approach. That's where the lid creases, there's no scars at all. And we really, for the lateral skull base, you can usually do a lateral cantotomy approach itself. So when do we actually use this? We can use it for repairing CSF leaks, for example, either post-trauma or post-reconstruction. Sometimes we have had orbital decompressions. They have gone into the deep temporal fossa, torn the dura, this is persistent CSF leaks. Or the supromedial region, you can have CSF leaks following terribly done BCRs, for example, or post-trauma. Apical orbital fractures, which we are not comfortable with putting reduction and where the vital structures are. Tumors of the middle fossa is becoming an emerging indication for tones approaches. Many will circulate seals and repairing infections becomes very important. So here's an example of a patient. Can I have one senior resident here? Just give a quick diagnosis. Dr. J. Prakash, can you point to one resident there? Or a fellow? A spot diagnosis. This is a spot diagnosis. It's an exam question. Oh, you don't want to pick on anybody. You want to be a nice guy. So anyway, you see an infiltrated lesion, predominantly in the soft tissue component on the orbital side, in the intraprenal side, and you can see the tail sign. Enhanced under meninges. This is a classic sphenoidal wing meningioma. And traditionally, this was all managed by the neurosurgeon through a pterional or a coronal approach. And the moment you tell the patients, I'm going to make a big incision, take a scalp arm, go to the brain, they disappear. And that's a very famous thing as well. So these are the cases where now, through a simple lip crease approach, because of our familiarity across the loop of the orbit, Dr. Shruti will be talking a little bit about it, we can now access it and manage it over here. Here's another similar patient who has got a majority of meningioma on the orbital side, a minority of meningioma on the intracranial side, where the ophthalmic symptoms far outweigh the neurosurgical symptoms. Again, through a combined approach, we are able to access it through the lip crease, which is absent on this side but present on the other side, so create a lip crease and we can go ahead and do it. And we have apical lesions like that, where sometimes we are uncomfortable going inside through big plagial approaches causing visual loss. And this is a 15-year-old boy, this is the last case I'm going to show, where apparently came in with some of the symptoms, had an imaging done. I call this an incidentaloma, incidental finding of something eroding the superolateral wall of the brain, bony lytic lesions, and a soft tissue right there. And a CT scan doesn't discriminate whether it is brain or any infiltrated lesion or tumor or so on and so forth. At the same time, because it's an incidentaloma, the parents said, I'm not going to subject my son to a major craniotomy kind of procedure. But again, through a stupid lip crease approach, we went and did a biopsy. It was a Langerhans histiocytosis in a 15-year-old boy. We kept the neurosurgeon standby thinking that if we eroded the dura, went into the brain, we may need his or her help. But we were able to do sufficient debulking of the entire histiocytosis that we have given not only a diagnostic approach but a therapeutic approach, following which the bone has remodeled as well. So that's a brief introduction to TransOrbital neuroendoscopic surgery. And I invite Dr. Shruti to talk about the applied anatomy of this region, the skull base. Thank you.
Thank the organizing team for having me here, Dr. Sultan sir and Dr. Ganga for having included me in this program amongst the stalwarts in ENT specialty. So in the next couple of minutes, I'll just take through the basic anatomy. So it is where we can be of help here. Just briefly on the applied anatomy. Now it is the combined efforts of the ENT, neuro, oculoplasty and with a little bit of radiology colleagues is where we can give a holistic treatment to these patients who require. Now how close are the orbital surgeons to the skull base and where we can break the barrier. So basically orbit is keyhole to the skull base. Now, a small little video on the anatomy of the orbit. So it's basically the frontal bone, we have the maxillary bone and the zygomatic bone which forms the rim of the orbit, and the other bones are, we have the lacrimal bone and posteriorly we have the ethmoidal bone and the greater wing of the sphenoid. So if you go a little posteriorly, if you look at the roof of the orbit, it is the orbital plate which is very closely associated with the brain. Okay, so this is where we is of interest to the where we can reach the brain easily through the orbital approach. Now the maxilla takes a little part where the floor of the maxilla. The inferomedial aspect of the floor is by the maxillary bone, and also we have the frontal process of the maxilla, that is the medial part. So that articulates with the nasal bone and the through the frontomaxillary suture to the frontal bone. and the lacrimal bone posteriorly. So now we also have the maxillary suture here. So let's pause this. Yeah, so this is of interest to us, especially when we are doing the lateral orbitotomy through a bone cutting approach. So that is where the frontozygomatic suture comes. And posteriorly, if you go, it is the greater wing of the sphenoid. You also have a smaller part, that is the lesser wing of the sphenoid. Now, within the lesser wing of the sphenoid is the so posteriorly is the lesser wing of the sphenoid. Now, within the lesser wing of the sphenoid is the optic canal, which has the optic nerve and the ophthalmic artery. So that is the posterior most part. Then you also have the greater and also the annulus of Zinn, where the extraocular muscles take their origin, and you have the supraorbital fissure between the greater wing of the sphenoid and the lesser wing of the sphenoid. So within the supraorbital fissure, we have the lacrimal nerve, we have the frontal nerve, we have the trochlear nerve, we have the superior branch of the oculomotor nerve, we have the inferior branch of the oculomotor nerve, mesociliary nerve, and the occlusal nerve, and also the superior ophthalmic vein and the inferior ophthalmic vein. Now, between the lesser wing or greater wing of the sphenoid and so between this is the greater wing of the sphenoid and the lesser wing of the sphenoid and the maxillary bone, we have the infraorbital fissure. So that houses the infraorbital nerve, artery, and the vein. So that covers the posterior aspect. Now, if you come medially, we have the ethmoid, we have the lacrimal bone, which has the lacrimal crest here, anterior lacrimal crest, the posterior lacrimal crest, and the ethmoid bone. So very posteriorly is this yellow one is the palatine bone. So along this medial orbital wall, we have the ethmoidal nerves and the arteries. So this basically comprises of the orbit in short, brief. So we also have the spaces of the orbit.
Myself, Dr. India, from Ashmi Hospital. I worked in the Arabic cancer for the last 15 years. We deal all kind of orbital surgeries. We approach by transnasal orbital. We don't approach this endoscopic to basically the sinus transnasally we approach medial wall and inferior wall approach. What is the lateral wall is super vision reach the middle fossa. So when it's a discussion over update what is we are doing and what is the different tones and what you transnasal orbital surgery, what is the transorbital nasal surgery.
Pradeep.
Yeah, I am Dr. Pradeep, senior consultant working at Unam Hospital also, and I have been associated with Narayan Visalia Hospitals, Bangalore for the past 15 years. I have been working with the neurosurgery team for the past 15 years, and as Dr. Rajni has told, this is something which our corridor is entirely different, and our approach towards the orbit is restricted towards the medial wall and the inferior wall and to certain extent superior wall. And always whenever I go for any lateral lesions, always my orbit and oculoplastic surgeon Dr. Dagan, whom we have been working with for almost 15 years, so he will come and take over. So I think tone is something which is a combined approach of ENT, neuro and the orbit surgery. So our corridor is limited because everything is endoscopic. Yeah, let us go for a discussion and let's see.
So our last formal presentation is Dr. Raviraj Hegde. In US, then we'll have a good interactive discussion. Thank you.
Hello. Yeah, I would like to thank the organizers, Dr. Bala, Dr. Anisutan, and Dr. Ganga also for inviting me here. So I started doing tones about 2 to 3 years back around the pandemic time. So just I won't dwell too much on the anatomy part because already Dr. Shruti has gone through it. Basically, it's consists of
7 bones in the orbit. So basically, it starts with the frontal bone at the roof, and then this is the sphenoid bone at the back, and then as we come forward, it's a zygomatic bone, and the maxillary bone which forms part of the floor as well, and then the medial wall, the lacrimal bone, and then just behind that is the ethmoid bone. And the last, the smallest bone, but the strongest bone in the orbit is the palatine bone at the back, which comes from below. So the orbit, it's like orbit is a very unique shape because it starts as a square-shaped cavity and then it ends as a triangle. So the shape of it is like a pyramid with how we go, and there's an apex and there's a base of the pyramid. And earlier, before I think this is one of the cases which is older cases that I've done. The neurosurgeon actually called thinking that there's a proptosis there, and this painless proptosis is not affecting the vision as such, but he was having a proptosis, so it was sent to the neurosurgeon to me. And when we did the MRI, we saw that it's at the lateral skull base area, just at the junction of the orbit, the sphenoid bone. So it is an osteolytic lesion which is it's eaten up the sphenoid bone, and as you can see that there's a tumor at the red star where it is there. That's where the tumor is, and it is osteolytic, so it is communicating both at the intracranially as well as extracranially, and I think it is not getting infiltrated. It is not infiltrated into the dura. But it was complicating, so we decided if we can approach it through the orbit side, then we could avoid a craniotomy in this case. So we, as Dr. Shruti already demonstrated, so just to take a seat, so as a skull-based surgeon, how would you approach such a case, such a tumor, if it's a lateral skull-base?
So lateral skull-base basically, so what we don't make a huge section of the lead, but we directly make the because our lead can
keep it close to your mouth.
So what I usually approach the lateral orbital lateral skull-base means we make incision in the lateral structure. We make incision there, and through the we don't make a huge incision. It will be around 5 to 6 millimeter, where our 4 mm endoscope can pass the endoscope. Sometimes we use a drill, local micro drill. We can dissect the tissues, and basically the corridor is the periorbital bone we reach in shape. So we don't enter into the orbit. We don't enter into the intraorbital or extraorbital. So we basically want to call the periorbital and the bone. So when you enter the periorbital, we can reach easily the lateral orbital wall and superior orbital wall. So if you want, even when you use a bar, and even with the bar, you can drill that lateral orbital wall and enter into the middle fossa. Even the tumor, the superior orbital fissure, you can easily enter, and you can easily dissect the tumor and remove it. That should be easier for us to continue, because we are expert in endoscope technique. So we will be comfortably hanging the debrider, everything, so we will be able to reach that space and be able to dissect the tumor.
So of course we also do endoscopy, but vision endoscopy. But in this case we didn't use endoscopy because much before I started to with my skull-base study. So this is a decreased thing, and we reached the rim of the orbit. Then periosteal incision was taken, and then this is the lateral orbital bone. We make cuts to it. So the anterior part of the rim, we call it marginotomy. So the marginotomy of the orbit. So then it gives us space to go posterior to the orbit, the lateral part of the orbit. So we crack it over, and then when we go posterior by using bone in we see this is the tumor, that red gelatinous lesion that we see, that is the tumor. That actually was a plasmacytoma. So the plasmacytoma which is eroding the orbit, and so but it is isolated orbital involvement of the plasmacytoma. There is no other lesions inside the body. And after we removed, we saw that the whole thing was removed, and then we could appreciate the anatomy where this is actually the skull base. So this is the dura that can be seen there, and then there's a periorbita, then there's a part of the that is held by the retractor, and those are the orbital rim, and the temporal muscle which is attached to the orbital rim. So this basically is a skull base surgery, but it's an open method. So then, so basically we close this, and this is and all we have is an incision that is here, and we've actually gone into the skull base and removed the tumor and come out. So tones, it's not a new concept, it's been there for some time. I think from the 90s there have been papers from the neurosurgery journals that to approach the orbit from, approach the intracranial fossa from different angles compared to the posterior orbit. Even though the nasally also you can approach the skull base, but the angulation is the problem with the nasal. Of course there are very new instruments that we can circumvent those angle issues, but the orbit gives a little bit of a open area, and you can use the regular endoscopes to reach the cranial spaces. So it gives you all the access to the different anterior skull base, posterior skull base, even the posterior lateral skull base as well. And even and also the only issue is that when we go from the orbit side, the safety of the nerves around the orbit apex is important. So that is where the role of the orthoplastic surgeons basically we provide the approach for the skull base surgeons. The more of the heroic part of the surgery is done by the skull base surgeons. So this is our only goal is to protect the globe and the nerves of the orbital apex. So while the surgeon does the main part of the job. So just to give a overview of what kind of cases we do on tones. So tones is such a way that it usually finds indication on its own. So this is a 4-year-old child who fell off from a second floor and fell on the cement road. And
so coming to the discussion of the tones, basically I have a vast experience on orbit. Basically what the in the CSF, first I come to the discussion of our topics. CSF rhinorrhea. Basically rhinorrhea means it's coming to the nasal cavity, it's not to the orbit. You don't get CSF to the eye. So I think most of the 95% of cases we are able to tackle with the transnasal approach. So this is a technique for CSF, we manage the cases, but what display the cases is a little different, where the roof of the orbit. But roof of the orbit, usually the roof of orbit support has been of a periorbital fat. Usually we have put support to, you don't get a leak through the orbit. So most of the CSF we approach transnasally. We are comfortable with our technique because we are able to approach transnasally entire anterior cranial fossa. Where we have difficulties means only the lateral frontal sinus, only the pneumatized frontal sinus where we can not be able to laterally. But most of the lesion we are through the front. Basically, our technique is we call functional endoscopic sinus surgery. So you can reach orbit through the nose, but this is not a functional technique. So we reach what is the basic principle of first means functional endoscopy. We are going to the ventilation, then we are going to ventilate the sinus. So what are the weakest? It has come to nasal cavity. So most of the tumors, most of the CSF we are able to reach through the medial orbital wall. So coming to the orbit, we have 360 degree orbit. So we can reach the optic canal to transnasally. We can reach the medial orbital wall transnasally. Even front superior orbit, one half we can reach medially through the transnasally. We have difficulty in reaching the superior orbit fissure. We are having difficulty reaching the lateral frontal sinus, extensor pneumatized frontal sinus. Sometimes the floor of orbit where we have some difficulty in excising. So what are the cases I have difficulty means chronic invasive fungal granuloma. These are the cases we usually start up between the orbital surgeon and ENT surgeon because it's a granuloma lesion which we are not able to pull it. So we need another surgeon to dissect and release. That is the things we manage these cases. And this is the COVID era. We have a lot of temporal lobe abscess. We have rhino-orbital cerebral mucormycosis. We have frontal abscess. We have temporal abscess. And we have a shortage of, we have a difficulty assessing neurosurgeon, difficulty assessing anesthetist to manage the cases. That cases, because of mucormycosis, we have frontal lobe abscess, we are able to drain to the transnasally. Temporal lobe abscess, which is the cases we have, which neurosurgeon have difficulty in handling the cases. That is the reason we approach the superior orbital fissure. We may incision the superior orbital fissure, and we are able to reach the optic canal and superior orbital fissure.
And then through the corridor, we can be able to build that lateral orbital wall. Then we can enter the frontal, enter the temporal lobe, and we can make a small incision at dura, and we can able to drain the temporal oxygen. These are the cases we have a lot of experience. The TransOrbital neuroendoscopic surgery, my experience is limited to the temporal oxygen. We are drained a lot of cases. I have 4 cases of temporal oxygen straight to the TransOrbital approach. And
it is very, first of all, let me say I'm very impressed by this. Completely change in philosophy, as you said, because for us, orbit was, no-go land, and that was the last area we would reach. And now we are looking at it as the main first step in an approach. So that's a fantastic change in philosophy. And also, they beautifully outlined the anatomy. So it's so easy to see what a wide corridor you have when you start looking at orbit as an approach. As a skull-based surgeon, I am used to a microscopic approach where we use usually a bicoronal incision or a hydro incision, lay open the whole area, and then dissect out the floor of the So this is seen very often in any number of cases of sinonasal malignancies, where the philosophy is wide excision, where you want to remove the whole thing and then pull the whole thing down along with the maxilla or front or whatever. So
evolution of this myself and Nagaraj used to sit and chat in the evening having a cup of coffee, and I was saying there's something coming new towards somebody in South Africa, lady is doing some work, we should go and visit at the park. And we were going through this and this, and this is oculoplastic surgery. I said, my cousin is there, oculoplastic surgery. Then he was saying, you should invite him for the conference. I was hesitating. He kept on persisting, have you phoned him, have you phoned him? I was not sure whether to call the oculoplastic surgeon for ENT conference. Then I phoned Mohan sir. Sir, can we call? He said immediately, no, he is a very good speaker, please call me. Then it was almost very close to the conference. I was not sure he is a busy man flying across the globe. So I phoned him, he said that yes, I am coming straight away. So that is how we evolved the whole concept. My perspective for the juniors is the way forward is you have to work with a team. You have to work with neurosurgeons, orthopedic surgeons, pulmonologists, whichever area you go, you have somebody who interact with transportation. I think that's how, and the way is now what happens is once we started doing a lot of transplant surgery, the CSF comes from the neurosurgery point, or sometimes they come to me, or so whoever gets a case, we get to operate as a team. So I think that's where the orbital surgery is going to go.
Thank you. That was trying to close the session because unless we have any further questions from the audience or from the panel.
I just have a small thing to say. Knowingly or unknowingly, sometimes we do tones. This is like way back, like I think about 4 or 5 years back. I remember there was this patient who came with a bullet injury, and this bullet was lodged between the ethmoid sinus and the orbit, like it was stuck there. And so with the help of my ENT friend Dr. Anisultan sir, we called him and I said, sir, we have to remove this. So we were like wondering like which side to remove. Either you push it to the ethmoid sinus or you push it into the orbit. And it was like so tightly stuck there. So finally we went in through the endonasal approach and slightly nudged it into the orbit. So we did a transcaracular approach and picked it up from the orbit. So this was like tones which we did many years back, and now that has come in. So I think that's a way to go about, and as Dr. Bala said, it is the collaboration that does a lot of things. Thank you.
So basically, orbit is we have a lot of lesion which has associated with the sinus or skull base. So it's basically a team approach. It's not a single man show, but we need a collaboration with the oculoplastic surgeon and ENT surgeon and the neurosurgeon, where we can do good result. So that should not be ego in catching that, but if you have, as an ENT surgeon, we are expert in handling the endoscope. We can use the instrument and everything. But as an oculoplastic surgeon, as an orbit surgeon, you have the cases. So you have the cases, even endoscopically, we can use optic nerve, orbital effects, even intracortically, we are more comfort. Nowadays, we are able to insert the periorbital, we can hook the muscles and into the intra-port compartment itself we can go. So if we had a patient recently 2 days before, we had orders, 4 years worth of orders coming to a woman. So which is they are able to not able because of the more is the superior water, which they want initially they plan to make a small incision something like. But I said comparatively, I can manage this kind of capability to translate. Basically the pus has gone from the ethmoid or conductance to the orbit. So if you train natural pathway, the patient have one sitting can comparatively get these cases. So basically most of the cases we have the teamwork, the result this is taken.
So thank you. It's time to close this last session before lunch. It was a wonderful session that we had. We are always told that we should have lateral thinking, and for us, translate endoscopic surgeons, I think this is a way to develop a lateral thinking, pun intended. So there was a wonderful demonstration of videos and anatomy in an area that we are not very familiar with. That was a great session. Thanks to